So now we've spent some time reviewing the problem of hypoglycemia in the hospital setting and how insulin can be used effectively to treat diabetes using basal bolus correction insulin. But it is important to note that despite this, insulin is a high alert medication. It's in the top 5 medications which has the most errors associated to it. And we do have to ensure that we manage insulin safely in the hospital setting. The Canadian Diabetes Association has put out some recommendations in regards to this. And what they recommend is that we have standardized protocols for insulin, sub-Q insulin orders, and that these have been shown in the literature to decrease errors and adverse events in patients. And they also help to have healthcare providers adhere to this basal bolus insulin if they're designed properly. The recommendation is also that there be protocols so that nurses can manage hypoglycemia without having to wait for a physician to order the treatment, so they should be easily initiated by the nurse, and that we should make sure that patients have access to blood sugar sugar at their bedside at all times if they're at risk of hypoglycemia. Given the recommendations from the CDA, the regional hospital network has worked really hard over the last couple of years to ensure that we improve the care of patients across our region. And we've ensured that most hospitals across the Champlain have pre-printed insulin orders to increase safety of insulin ordering in our hospitals. We have an example here of an order set that's being used in the region. And you can see that it promotes the use of basal. We say mealtime here, which is our bolus insulin. And then our correction doses here at the bottom. They provide physician guidance with how much to order based on the patient's insulin sensitivity. And also, we don't use any dangerous abbreviations. And we have some safety measures where we block off areas where patients shouldn't be receiving a particular type of insulin. So we have embedded safety into the pre-printed orders, and using this is really important and makes a difference to the safety of patients in the hospital when we're using a high-risk medication such as insulin. Now, of course, one of the risks when we're using insulin is that there is always a chance of hypoglycemia. It is an inherent risk of treating diabetes. Hypoglycemia is always there. It's blood sugar below 4. Many of you have been exposed to this in the past. And the symptoms of hypoglycemia have not changed. They're your classic symptoms of shaky, sweaty, lightheadedness. But in the hospital setting, when patients are sick with something else, they may have more difficulty recognizing their hypoglycemia, and therefore nurses have to be hypervigilant. And confusion or changes in behavior can be a sign of hypoglycemia, and it's important to be aware of this and to check the patient's blood sugar when you suspect hypoglycemia. Part of the issue is that healthcare providers are very afraid of hypoglycemia, and they tend to overtreat it. And they also tend to hold doses of insulin, as we have discussed in the past, because of their fear of hypoglycemia. But really, as we've said, it's more important to treat the hypoglycemia, not hold the doses of insulin, but rather to reduce the doses when necessary. So the treatment of hypoglycemia is quite straightforward, and it's the same in every situation. We need to recognize the symptoms. We need to confirm with a blood sugar test that the blood sugar is actually low. We treat with a fast-acting sugar or a simple carbohydrate, and the standard treatment that's recommended is 15 grams of sugar to relieve the symptoms. We will repeat the test in 15 minutes. It does take about 15 minutes for the blood sugar to reach the bloodstream, and we will repeat this process of treating and retesting every 15 minutes until we have a blood sugar that's above 4. Once the blood sugar is above 4, then we follow with a snack to ensure that the patient's blood sugar is maintained and that they don't have a recurrence of their hypoglycemia. And the snack should always contain some carbohydrates, at least 15 grams, and some protein. This is often called the rule of 15 because we give 15 grams of a rapid-acting sugar, wait 15 minutes, and then give another 15 grams with protein at the end. 15 grams of fast-acting sugar will raise a patient's blood sugar in general by about 2 millimoles. If the blood sugar is lower, is a severe low, under 2.8, then it's not necessary to double the dose, but to give 20 grams of carbohydrates instead. So some example of 15 grams of carbohydrate that you should have easily available on the wards in the hospital. You can have 15 mLs of sugar, which is the equivalent of 3 teaspoons of sugar or 3 packs of sugar in some water. 3/4 cups of a juice or a regular soft drink because we want sugar. And then we can use glucose tablets. They come in many forms, 3, 4, or 5 grams. So you need to make sure that you give enough glucose tablets to get at least 15 grams of glucose. So check with your hospital what you have available on hand. And if you have glucose tablets, be sure to know how many grams per tablet so that you give the right amount of glucose. Candy will also work. A tablespoon of honey. All these things are about the equivalent of 15 grams of carbohydrate. If you need to give 20 grams, you easily just top up. Instead of 3 packs of sugar, you would give 4. Instead of 3/4 cups of juice, you would give a whole cup, and so on. If the patient is unconscious or not able to eat but has IV access, the steps are exactly the same, except now instead of giving PO fluids or sugar, then we're going to give it intravenously. And the Canadian Diabetes Association recommendation is that we give somewhere between 20 to 50 mLs of D50, which is the equivalent of 10 to 25 grams of glucose intravenously, so IV direct over a couple of minutes. And then we check the patient again, and we would repeat, depending on your hospital protocol, what you're allowed to do. So you have to check with what your policy is at your hospital. And then once the patient is conscious, we would again feed the patient, as long as they're not NPO. We would have to give them a 15 grams of carbohydrate and protein, again, to ensure the blood sugar doesn't drop again. If the patient's NPO, then you would need to ensure that there's some kind of intravenous glucose drip going on so that the patient doesn't have hypoglycemia again. Examples of snacks that could easily be found on most hospital wards would be some crackers and cheese, a toast with peanut butter, a half a sandwich. If you don't have those things available, but you have meal supplements, about a half a serving or a half a can of any meal supplement will have some protein and carbohydrates and should be sufficient to replace the snack. So it's important to remember that unless the patient's NPO, you always have to give a snack to maintain that blood sugar. If the patient doesn't have IV access, then glucagon is usually the treatment of choice. Again, you'll have to see what your hospital protocol or policy is, but glucagon is usually given in a sub-Q or IM injection. It stimulates the release of the glycogen stores of the liver. It does have to be reconstituted. It's a powder that comes with a diluent, and you have to dilute the powder before you administer it. And it usually can be repeated once or twice as needed, but again, you will have to refer to your particular hospital's protocol or policy about this. Another key message that we want to put out there for you is that often there is lack of communication between healthcare providers about managing diabetes. The key to successful diabetes management is to have an interdisciplinary team approach, which includes the patient at the center. We have to remember that patients manage their diabetes at home and that they're very knowledgeable about their own disease. And we often it's difficult for those patients to relinquish control of their diabetes management, and they can certainly inform us about what works best for them, and to be sure that we keep communicating with them, informing them of what we're doing with their diabetes is really important for their safety and also for their patient experience. So in that vein, if the patient is able to and is capable and it's appropriate, we should allow patients who wish to manage their own diabetes in hospital to do so. But it is important to remember that they're in an acute care setting, they're ill, so some of the illness or some of the drugs that we may be giving them may be impacting their judgment or ability to make decisions, and we need to make sure that patients are still safe to do this, and this should be assessed on an ongoing basis in case their medical condition changes. And hospitals need to have guidelines and policies and to ensure that this is done in a safe manner. The other place where things tend to fall apart for patients once they've been in hospital with diabetes is that we need to help with transition out of the hospital at discharge, and we often aren't very good at informing the patient about when and how often they should be checking their blood sugar. We need to make sure they know how to manage and identify that they're having hypoglycemia, how to treat it, update them on what to do with their medication. We often change medication when patients are in hospital, so we need to let them know if they're to resume their previous treatment, or if we've changed anything or added any new medication. We also need to ensure that their primary care provider is aware of what we've changed and what the plan is, so that we can have a good post-discharge follow-up to ensure the patient is safe, and that those changes are still appropriate once they're home and out of their crisis situation in hospital. So to help with that, the Regional Hospitals Diabetes Network has developed some tools to help your organization, and we've developed a discharge information guide that can be given to patients. It's available both in French and English. And we've also developed a sample letter to provide to the primary care provider. These are all available on the Lynn SharePoint website, and member of the network from your hospital can have access to these. So please ask for them if you can start to use them. They could help with that transition to home after discharge. The other thing that we've worked on at the network is that we've created a series of surveys that could be used and are at your hospital's disposal. Again, available on SharePoint. And the results of these surveys can help any hospital to see where they can make improvements in managing diabetes for their patients based on the results. And I have an example here at the Ottawa Hospital, which is one of the hospitals in our region here. Since the implementation of standardized protocols, they've surveyed patients regularly, annually, to see how patients are satisfied with how we manage their diabetes. And we see an improvement since 2011. Patients surveyed who were very satisfied with the treatment of hypoglycemia went from 50% to 77%, which is a significant improvement. And patients who were very satisfied with how hyperglycemia was treated went from 56% to 71%. And overall satisfaction, patients who said they were very satisfied with how their diabetes was managed in general went from 53% to 75%. So standardizing the care has made a difference at the Ottawa Hospital, and it can make a difference at yours as well by using those standardized protocols. Some useful links that would be interesting if you have time and you have a particular interest in increasing your knowledge of diabetes are here, and I encourage you to go and look at them. There's the Alberta Health Services as a nice website where they really go through basal bolus insulin therapy in great detail. So if you want to know more about that, the Canadian Diabetes Association guidelines are available free of charge to everyone. And I encourage you to look at them and to stay tuned for 2018 when the new guidelines come out. And I suspect that basal bolus insulin will still be part of the guidelines in 2018 because it is a very effective way of managing diabetes. If you have a particular interest or want to work on standardizing protocols or and improving safe medication practices, the ISMP, Institute for Safe Medication Practices, has also a website with many resources and examples of protocols and guidelines for developing insulin order sets. And I want to conclude by thanking you for participating, and together, hopefully, we can improve the care of patients with diabetes across our region. Thank you.